Thanks to our four speakers for these really interesting talks, and now we're opening up for questions.
So I'll ask the complementary question to what Jim Stevens asked in the last session. That is, I think it's clear that whether it's toxicology or disease progression, the systems, whether they're animals or humans or even in vitro models, are highly complex, involving multiple pathways, and so the complexity is real, kind of demanding the use of more and more computational and systems biology tools. So the question, maybe it's primarily to Jim and Brian, is what is the state of the implementation of these approaches in the pharmaceutical industry, and where do you think it's going to go and why?
So I always coach young scientists that the valley of death for technology development is in between the time when you know the answer and the time when you can actually get people to use it. So we are not implementing all of the technologies that I showed you. In part, it's this matter of incentives. So if I can get a molecule into the clinic with a standard non-clinical safety package, why wouldn't I do that? So what is the advantage to actually know more that might create additional concern? That said, I do think we're moving that way. I think in particular on the efficacy side, computational approaches to understanding how we select targets is well ingrained. The question is, will we make the same sort of leap to understanding how to use computational methods to actually predict the probability of safety, precisely the probability that something might happen?
I would support that notion. Having bridged between the safety and the pharmacology world, there's much more appetite on the pharmacology side for embracing novel ways of working. There's more flexibility. There's less hard edges around some of those areas. And so, I mean, many of us see that space as a proving ground to help build confidence in some of these novel approaches that ultimately can bridge into safety testing where there is a significantly greater conservativeness.
So I have two questions. One for James. Are there any examples of chemicals that produce an effect that you detect by pathway analysis that don't result in any pathology in the tissue? Or is every case, is every case associated with pathology when you have a very significant, some level of change?
If you'll allow me, let me slightly modify your question. I'm going to say any adverse pathology, all right? So hypertrophy is generally not considered adverse, and a pathologist would call that adaptive. In fact, I wasn't able to get into it, but activation of the NRF2 pathway shows a high correlation with the incidence of hypertrophy in the absence of cell death. And in fact, if you look at the effect size for the association between NRF2 activation and the likelihood of getting a pathology, it's negative. That means you're more likely to get pathology when you repress NRF2 activation than when you activate it. Yet there are many papers in the literature trying to use NRF2 activation as a sign of toxicity. So other kinds of pathways would be if you do a partial hepatectomy, the remnant part of the liver that's actually surviving, cells are dividing, etc., it's not technically damaged. There's massive gene expression there, because you're seeing all the changes that are associated with the stereotypic responses of the tissue to adapting to the insult that occurred by removing 2/3 of the liver. So I hope that satisfies you, but that's the type of approach I would take to that question.
Well, in fact, I mean, we're in the business of making molecules that are bioactive, right? So there's lots of things that happen, and it's that distinction between an adaptive or a pathologic change in an acute or chronic setting that's the real challenge.
Yeah, actually, I'll comment on that, and then I'll ask the other question. As I think about toxicology, and I'm not a toxicologist, by the way, although I'm trained in pathology, I really would love to see a official and tested group of changes, histopathological changes that are not pathology, that are adaptive, so that we can make those strong differentiations, unless that's already established. But I'd like to see it established digitally. So towards that, What we're trying to do is in our group is to develop a three-dimensional histology that allows for computational analysis that is not possible currently with histology-based studies. These are 3D changes in tissue, which are universal in significant human disease, are three-dimensional changes in tissue architecture. And it's impossible to measure those features because a lot of those features are larger than the tissue slice thickness, and the sampling of histology is very, very rarely more than 10% of the tissue sample that you take. And so if we could increase the amount sampled and increase the quantitative data, that would be really great. So I'm wondering what your, in terms of focus on phenotype, I'd actually also like to ask whether there are, how many studies there are there available data, histological or tissue data, from failures in pharma that we want to learn from. So what kind of changes in all the organ systems occur, and are there correlations between those in the future as you test drugs? You've got to learning from the failures, in other words.
So the short answer is there is an incredible amount of opportunity in our failures. And unless it is specifically relevant to another part of our portfolio, the reality of it is that we're in a business, we don't go back and dig into those things. And so there's an incredible amount of potential sitting there. Having said that, and the kind of work that Jim's doing, we do, when you're trying to develop a novel approach, go get some of those classic things. One of the problems that we have is the stuff that's probably most meaningful, for particularly in the context of understanding human translation, we just don't go that far, right? Something bad happens, you just get rid of that drug before you take it to patients. And so there's a gap in that human extrapolation for some of the stuff that is probably most meaningful. So potential is there. Some focal areas of depth to that, you know, when you get folks like Jim digging into some of these things, but a lot of unrealized potential, I think.
Yeah, so I'm not a pathologist, but I think we need to be very careful in defining non-adverse versus adverse changes histologically, because a lot of our definition is going to depend on a snapshot in time at a given dose. And had we treated longer, would that steatosis that we'd seen progress to steatohepatitis? Maybe, maybe not. There's a lot of cases in the literature where you can continue to treat through pathologies that then resolve because you have some sort of adaptation event. So I think there just needs to be a little careful thinking about how to approach that question.
A lot of careful thinking.
But
that's a good point.
if I could have one thing that I currently don't have, it'd be higher throughput EM, electron microscopy. Because when I see hypertrophy, if you exclude things like phenobarbital or peroxisome proliferation, which are not normal hypertrophy, I see cells get bigger, and I can see mitochondrial biogenesis occurring because you're upregulating the transporters of the outer and inner mitochondrial membrane. I can see increased splicing of ribosomal RNAs as part of ribosomal biogenesis. I can see upregulation of the TRIC complex, which folds tubulin. Those things are observable at the EM level, and you could actually connect molecular and transcriptional regulation with subcellular organellar level responses. And that would be absolutely fascinating to do, to use that level of morphological data to connect them. So if you've got that kind of capability, it'd be great to talk with you about it.
So to do that, you need to have both lower resolution and higher resolution imaging, because when you do EM, you got to select which cell, what part of the
Exactly.
cell. If you select the wrong cell, you may not see the change at all. So you have to have it within the context of the whole structure of the tissue and the architecture of the tissue, and then say you see a change, oh, that looks suspicious, and then you go look at EM. I think
Right.
that's a great coordinated approach.
And there's a huge amount of heterogeneity across the liver lobule or the proximal tubule of the kidney in responses, and maybe things like laser capture allow us to go in and actually look at transcriptional responses, et cetera. There's a lot left to do, but I think the promise is huge.
We have time for one more question, if anyone has another question. Okay. Well, we can break for lunch. We should come back here by 1 p.m. when we'll start up again. Thank you.
Sorry, I was late. I was talking.
knew exactly what you were doing.